Okay, just introducing Andrei Gafita from Johns Hopkins. Thank you, Andrei.
Thank you. We will talk in the next 10 minutes mostly about prognostic and predictive biomarkers for PSMA radioligand therapy. And I want to stress from the beginning the impact that a prognostic and a predictive biomarker they have on the patient care. And I think it's what Oliver touched a little bit on it. A prognostic biomarker can tell us and the patient how he's going to do independent of the treatment. A predictive biomarker can help us as clinicians to define which is the best next treatment for the patient. These are my disclosures. I'm going to start with the ctDNA, with the data from the phase 3 PSMA-4 trial, which randomized patients to lutetium PSMA 617 versus a change in AR size. The trial met its primary endpoint, and now the FDA regulatory approval is awaited for the lutetium PSMA in the pre-chemo mCRPC setting. Dr. De Bono was kind enough to share his slides with me. These were presented at ASCO 2024. And he defined a cutoff for the ctDNA fraction at baseline of 0.5%. And he demonstrated a higher ctDNA fraction, both for the lutetium PSMA and the change in ARPI, was associated with improved outcome. This is validating when both treatment arms were combined, meaning a higher ctDNA fraction translates into a higher risk for shorter rPFS. This data was partly showed by Oliver. It's from the therapy data which randomized patients to lutetium PSMA 617 versus cabazitaxel. And they found that a higher ctDNA was associated with lower rates of PSA response, both for the ctDNA below 2%, between 2 and 30%, but not for higher than 30%. And these curves reiterate the predictive value of the ctDNA for the lutetium PSMA 617 versus cabazitaxel. We can see there's absolutely no differentiation for the cabazitaxel among the three groups, or for the lutetium PSMA, we do see a nice differentiation, particularly for the ctDNA below 2%. Now, moving to the imaging-based biomarkers, the first one that was proposed was the whole body tumor SUV mean 10. This comes from Michael Hoffman's group from Peter Mack. And they found in a secondary analysis from the therapy trial that a higher SUV mean, higher than 10, is a predictive biomarker for the PSA response rate. There were 91% response rate versus 52% for high versus low SUV mean. However, when we look at the PSA PFS and rPFS data, things are changing a little bit, and the SUV 10 becomes only prognostic. And looking at the probably most important endpoint, the OS, SUV 10 was also only prognostic and not predictive. And similar for the tumor volume, the FDG PET, only prognostic and not predictive for the overall survival. The nomograms were developed in 2021. We have looked at about 270 patients who received lutetium PSMA in the real-world setting. We looked at baseline 17 parameters, similar to what Oliver was mentioning, taking the whole patient into consideration. We looked at demographics, initial diagnosis info, treatment history, baseline clinical parameter, and baseline PSMA PET parameters. We looked at OS, PSA PFS, and PSA 50 as endpoints. We used 200 patients for the training data set and 74 patients for the validation data set. The goal was to identify responders versus non-responders, so we stratified the patients into low versus high-risk group. We see the PSA PFS data and the same associations with outcome among the three cohorts, the development, validation cohort, and then when we merge them. Similar result for the overall survival. Patients at low risk for progression or death, they had longer overall survival and longer PSA progression-free survival. Then we try to establish the prognostic versus predictive value of the nomograms. Dr. Hoffman was kind enough to share the therapy data set. And we found that the nomogram was, again, only prognostic for the overall survival. Patients at low risk had longer overall survival both in the lutetium PSMA and cabazitaxel arm. Similar result for the PSA PFS data, longer time to PSA progression in the low-risk group versus high-risk group, both in the lutetium PSMA and cabazitaxel arm. For the PSA response, we found similar results as for the SUV10. There was a predictive biomarker. There was 70% versus 27% PSA response rates in the low versus high-risk group, with no differentiation in the cabazitaxel arm with 36 versus 38%. Then we had a really nice group of investigators from the VISION, and we aimed to develop an updated nomogram using the VISION data. The parameters that were found to be prognostic was the whole body SUV max, the time since prostate cancer diagnosis, opioid use, this was novel compared to previous nomograms, the liver AST, hemoglobin, lymphocyte count, the presence of the PSMA PET lymph nodes, LDH, alkaline phosphatase, and the neutrophil. These were for the overall survival. Things were a little bit different for the rPFS, which I think emphasizes that different endpoints relate different with the patient characteristics. The SUV max was again found at time since prostate cancer diagnosis, opioid use, lymphocyte count, the presence of liver metastasis on the CT, as well as the LDH and the alkaline phosphatase. There were way fewer parameters for the PSA response rate, the PSA 50% decline. The tumor expression, the PSMA tumor expression, whole body SUV max was again lymphocyte and only the alkaline phosphatase. This was another secondary analysis from the VISION trial where the baseline PSMA PET scans was performed tumor segmentation. They were quantitatively assessed, and the whole body tumor SUV min was splitted by quartiles. The cutoffs were 6, 7.8, and about 10. We do find a linear correlation, as Oliver showed before, between the SUV min and the outcome for the rPFS, and we do not see any differentiation among the 4 groups in the standard of care arm. For the OS, the results were a little bit different. We only see a differentiation in the lutetium PSMA arm only between the SUV higher and lower than 10. There was no differentiation for the lower quartiles. And again, for the standard of care arm, there was no differentiation among the 4 groups. We also see very nicely on the forest plots that the tumor PSMA expression favors lutetium PSMA compared to standard of care among all 4 groups in the quartiles. We did perform at Hopkins a single center retrospective analysis, only 71 patients. We tried to see and compare the prognostic value of the previously established biomarkers and test a novel AI-based technology. For the PSA response rate, I think this goes to Louis' point. If we look at the non-responders, which should be of interest for us, not the great responders, but those that do not benefit from the treatment should rather go get taxanes, for example. For the SUV, they had 30% PSA response rate. With the nomograms in the high risk, they had 90%, and with the AI, they had only 6%. For the PSA, PFS, and the OS, we did see the SUV10 has a lower prognostic value compared to the therapy trial, which may be related to the fact that the patient population is different. The FDG PET was using the therapy, while in our cohort was used only PSMA PET according to the US drug label. The nomograms were performed equally well as previously, and the AI had also a similar comparison to the nomograms, just with a lower prognostic value for the overall survival. Now, switching to the response biomarker, Michael Morris nicely presented the PCWG3, which includes the CT by RECIST and the bone scan by the famous 2+2 rule. And we did compare several new response criteria for the PSMA PET, reiterating the need for new criteria for the PSMA PET. And we compared to RECIST, which has a novel approach. It does combine the change in the whole body tumor volume and combines to the new lesions, taking advantage of the PSMA PET, where the whole body can be assessed. We did find that both the adapted PCWG3 and the RECIST were highly associated with the overall survival. However, we did notice a high discrepancy among the progressor rate. We did see about half of the patients with adapted PCWG3, they had progression at 12 weeks after starting lutetium PSMA, and only 1/3 of the patients had progression by RECIST. So overall, about 1/5 of the patients, there was a mismatch. So we tried to see whether there was overcalling progressor or not. And then we plotted only the patients who had progression by adapted PCWG3. And we found that actually patients who had progression by RECIST, they had significantly shorter survival compared to those who do not. So the takeaway message would be the lesion-based assessment in PSMA PET may overcall progression and may lead to premature treatment discontinuation. Also, a caveat, this was in late-stage mCRPC. Patients had many metastases. The results may be different in early-stage prostate cancer. And this is the RECIST we trying to support the community, increase adoption. We established an online educational platform, which is for free for the entire community. We also have a DICOM viewer where radiologists, nuclear medicine physicians can go and use the software for free and learn to assess RECIST for their clinical practice or clinical trials. We also had a great time at the E&M. I'm going to skip. So takeaway messages, the baseline ctDNA fraction is a prognostic biomarker and hopefully a predictive biomarker for not only for rPFS but OS. The nomograms and the tumor SUV mean are prognostic but not predictive. FDG PET is prognostic, but we do not have any data on being predictive biomarker. Its added value in the patient selection is yet to be proven. AI may be a next generation of biomarkers. And lastly, RECIST is an evidence-based biomarker for response assessment.